infection control before, during, and after the COVID-19 pandemic. My name is Eve Cuny. I'm the Director of Environmental Health and Safety, Associate Professor and Assistant Dean at the University of the Pacific Arthur A. Decontamination School of Dentistry in San Francisco, California. I'm also the Chair-elect for the Organization for Safety, Asepsis and Prevention, OSHA. Now, before we encountered COVID-19, the standard of care in dental practices was called standard precautions. And these were a set of infection control practices that healthcare personnel used to reduce transmission of microorganisms in healthcare settings. Standard precautions are intended to protect both healthcare personnel and patients from contact with infectious agents, because we're aware that in dental settings, infectious disease transmission has occurred from patient to healthcare worker, from healthcare worker to patient, and also from cross-contamination from patient to patient. Standard precautions should be used by healthcare personnel caring for patients, regardless of the patient's diagnosis and whether or not the patient is known to have a communicable infection. So in other words, standard precautions should be used for all patients all the time. There are several elements that are included in standard precautions. These include proper hand hygiene, the use of personal protective equipment such as gowns, gloves, masks, and eye protection, respiratory hygiene and cough etiquette, sharp safety, including engineering and work practice controls to reduce the risk from sharp injuries, but also proper disposal of used sharp disposable items such as needles, blades, and the ends of orthodontic wires. It includes safe injection practices for IM and IV injections. It also includes sterilization and disinfection of dental instruments and devices, in addition to the cleaning and disinfecting of environmental surfaces, both clinical contact surfaces, which should be cleaned and disinfected after each patient, and also cleaning and disinfecting of housekeeping surfaces as necessary, such as floors and walls. Standard precautions also apply to percutaneous or mucous membranes exposures to patient body fluids, because they could involve bloodborne viruses such as hepatitis B, hepatitis C, and HIV. So standard precautions applies primarily to bloodborne diseases or diseases that can be transmitted through contact with any other body fluid. Of course, at the beginning of this year, we began to hear about the SARS coronavirus 2 that causes COVID-19. And because of that, we've had to dramatically change our infection control practices. One of the guidelines available to assist us in determining what needs to be done in a dental setting are the Interim Infection Prevention and Control Guidelines from the Centers for Disease Control and Prevention, the CDC. These have been updated a couple of times. The last update was on June 17th, and you can check the cdc.gov website for any future updates because they are changing rapidly. Now, I know for a period of time at the beginning of the 2020 and towards the spring, many dental practices closed temporarily or were providing only emergency care to patients because of the concern over the risk of transmission of COVID-19 through aerosol generating procedures. However, as we moved into the late spring and early summer, and dental offices began to provide routine care for patients, as did other healthcare providers, the Centers for Disease Control and Prevention also provided a guidance, which was a framework for healthcare systems to resume care of patients. It covered providing care in the safest way possible, including the use of telehealth, screening patients via phone or via Zoom healthcare or other device that can be used to determine whether or not the patient needs to come in for an appointment, and to also follow infection prevention recommendations, especially the new interim infection control guidelines. They also consider that services may need to expand gradually rather than if a practice has been closed or nearly closed and seeing only emergency patients. Rather than trying to go back to everything the way it was before, we need to modify what we do and consider it to maybe take an expansion of services gradually to make sure that we're doing everything as safely as possible. Looking at things like the local epidemiology, is there a lot of community transmission going on in the location of the dental practice? If so, it may be wise to take things a little bit more slowly. Prioritizing procedures that could cause harm to the patient if further delayed. Surgical procedures. Patients who are in the midst of treatment may have temporary provisional restorations on their teeth that need to be replaced with the permanent. Patients who are awaiting prostheses that will allow them to eat properly. Also prioritize at-risk patients that would benefit the most from care. So patients that have an infection and also maybe have a comorbidity of diabetes, that would be important to provide care for those patients to resolve their infection. So because of COVID-19, we've expanded beyond what are just considered standard precautions, which I mentioned at the beginning of this presentation. Of course, those are used in the care of all patients and continue to be important. But what we've needed to do since COVID-19 is also take a look at transmission-based precautions. And these are precautions that are an addition or another layer to standard precautions because they're geared towards preventing the spread of certain pathogens or pathogens that transmit in a way other than through body fluid contact. So one of the transmission-based precautions is called contact precautions, which is for diseases that can be transmitted through touch, such as methicillin-resistant Staph aureus or MRSA. And then those diseases that are transmitted through the droplet route require another level of precaution. And those that are transmitted through the airborne route require an additional layer. So we'll talk a little bit about those because that's really what's changed for us in dentistry. When we look at the OSHA, the risk pyramid, this is through the U.S. Department of Labor did a study of different types of employment and which types of employment posed the greatest risk for transmission of COVID-19. And they divided that into very high risk, medium, and then low risk. And what they determined was in dentistry that our aerosol generating procedures on known or suspected COVID-19 patients presents a very high risk of transmission. And then aerosol generating procedures on well patients and any type of procedure on a COVID-19 patient would create a high risk to personnel who are working on that patient. And then the moderate risk category would be urgent or emergency care, but no aerosols. And of course, low risk would be people that are doing administrative duties in the dental practice but are not having direct contact with patients during patient care. So when we look at how to control these risks, we look at what's called a hierarchy of control. Ultimately, you would like to eliminate a risk. That is the most effective way to reduce risk. But of course, we can't physically remove the hazard because we're treating patients. And so elimination is not a possibility in this case. And neither is substitution. We can't replace the hazard with another one. So that works in things such as hazardous chemicals, where you could potentially use a less hazardous chemical, but it doesn't work when treating patients. So what we look for are ways that we can control risk through either engineering controls, which would be the most effective that we have. And that would be things like controlling our ventilation systems, adding HEPA filtration, some of those types of things, physical things that can be done. The next would be administrative controls, which would be changing the way that people work. So looking at, some of the use of a rubber dam, for instance, use of high volume evacuation. And then finally, what's considered the least effective is PPE. And the reason it is effective if used properly, but the reason they consider it the least effective is because if people don't use PPE properly, that they can actually increase their risk, and therefore it's subject to human error. So when we look at transmission-based precautions, one of the things we look at is this guideline that came out in 2007 from the Centers for Disease Control and Prevention. And this was really aimed at hospital settings where they're treating patients, for instance, that might be infectious for tuberculosis, where you need to take airborne precautions, or treating patients with Measles, which is a highly infectious disease that's transmitted through both droplet and airborne routes. And so these precautions haven't typically been something that we've talked about much in dentistry or that we've employed in a dental practice. But again, with the emergence of COVID-19, we've had to really look at this. So these transmission-based precautions that I'm talking about are for patients who are known or suspected to be infected or colonized with infectious agents, including certain epidemiologically important pathogens, and these require additional control measures to effectively prevent transmission. And as I mentioned before, things like in a hospital setting, they'd be looking at things like methicillin-resistant Staph aureus or vancomycin-resistant enterococci. So, a number of those types of diseases that we really associate with inpatient settings. But of course, airborne transmission is another concern, and that would be things like influenza or COVID-19 or measles or tuberculosis, which can be both. Some of those can be both airborne and contact transmission. So I'd like to spend a couple of minutes going over mainly the droplet and airborne transmission, since contact doesn't really apply in the context of COVID-19, but just so that you understand, I've included it here where direct contact would be where microorganisms are transferred from one infected person to another without a contaminated intermediate object or person. So it's me transferring a disease through contact directly to another person. Say I'm a Staph aureus staph carrier, and I touch somebody else, and they have a break in their skin or something, and then they contract the infection. It could be mucous membrane contact, or for instance, one of the things that used to be pretty common in dentistry was herpetic whitlow, which is herpes of the skin or fingers. And that would be from unprotected touching of a patient's oral mucosa or fluids. So prior to wearing gloves, dentists were more likely than the general population to have herpetic whitlow of the fingers from touching a patient's oral mucosa, and the patient was harboring the herpes virus. And then indirect contact would be when this infectious agent transfers through a contaminated intermediate object or person, such as you would touch your hand to a contaminated surface or equipment, or instruments that have been inadequately cleaned and sterilized between patients' uses. That could be an indirect contact with an infectious agent. So contact precautions are simply that people wear gown and gloves for all interactions, and that PPE is put on before entering the treatment room instead of, at the point of care, and that it's removed and discarded as you're exiting the patient's room rather than carrying it out into other areas of the clinic, and that it's designed for inpatient settings colonized with certain pathogens, such as multiple drug-resistant organisms. Now, droplet transmission is where we really get to talk about COVID-19. COVID-19 is believed to be primarily transmitted through droplets. And droplet transmission occurs when respiratory droplets that are carrying infectious pathogens transmit an infection by traveling directly from the respiratory tract of the infectious person to an individual's susceptible mucous membranes. So for instance, when an infected person coughs or sneezes or even speaks, they can release these respiratory droplets that, if they come into direct contact with another person's mucosa, can cause disease transmission. And that's why, for instance, with COVID-19, the recommendation is that we maintain 2 meters or 6 feet of space between ourselves and other people, just to prevent those droplets, because droplets don't travel long distances. There are larger particles that are released from the person's mouth or nose, and then they drop to the surrounding surfaces fairly rapidly. They can also occur during certain procedures in medicine. That's during suctioning or endotracheal intubation or cough induction. Certainly in dentistry, we express droplets when we spray air and water into a patient's mouth. And we create not only droplets, but also aerosols. Pathogens, as I said, transmitted by the droplet route have not been transmitted through the air over long distances. That's really how airborne infections are transmitted, is over longer distances. So the SARS coronavirus 2 is recommended to take droplet precautions. However, the next level, which we'll talk about in a minute, would be that if you're doing an aerosol generating procedure, using an ultrasonic scaler, using a high-speed water-cooled handpiece, spraying air and water from an air and water syringe, then the recommendation is to take airborne precautions, or to take some of the elements of airborne precautions, not all of them. And I'll explain what I mean by that in just a moment. We did learn some things from the SARS outbreak back in 2003. In fact, I've done quite a bit of literature searches on aerosol generating procedures and what kind of science is there for recommending things like external vacuum systems or enhanced filtration. And I found that a lot of these articles were written, or actually were published in 2004, which makes sense because it was in the time after the 2003 SARS outbreak. And from SARS, what they found was that airborne transmission could occur over a limited distance, such as within the room, and that's not been proven, but it's certainly been suggested by the evidence. And that's true of other infectious agents that are transmitted through primarily droplet, such as influenza and norovirus. So the droplets that we're talking about are generally considered to be equal to or greater than 5 microns in size, which means that they can't enter the respiratory tract, but they can come into contact with your mucous membranes. And also because they're of a larger size, they don't travel as far as the distance. However, droplet nuclei can occur when there's a desiccation of a suspended droplet. And that can be a smaller size, less than 5 microns. And those droplet nuclei can be associated with airborne transmission. So it's really a fine line between, in some cases, between droplet transmission and airborne transmission. And talking about COVID-19, really when we're talking about the precautions that we're going to take, we're kind of straddling the line between droplet and airborne. And of course, standard precautions is always that foundation that we have of infection prevention. Organisms, however, that are transmitted solely by the droplet route do not remain infective over long distances and don't require special air handling and special ventilation. What it does require is that a patient be placed in a single room if possible, that the patient wears a mask when they're outside of that room or around other people, and that all providers wear a mask when they're entering the room, that you don't wait until after you get in the room to put on the mask. Special air handling, ventilation are not part of these precautions, and also neither are respirators, or filtering facepiece respirators. So what we want to talk about now is airborne transmission, because that is a possible transmission route for COVID-19. Airborne transmission occurs when either airborne droplet nuclei or other small particles that are in the less than 5 micron range, which is considered the respirable range. That's the range of size that's small enough to enter into a person's upper and lower respiratory tract. And then it contains those droplet nuclei or small particles would contain infectious agents that remain infective over time and distance, such as spores of Aspergillus and also Mycobacterium tuberculosis. Other examples of agents that are transmitted by the airborne route include measles, which is both droplet and airborne, and varicella zoster, which causes chickenpox, which is also both droplet and airborne. And the reason I say that is because there really are 3 classifications of organisms that transmit through the airborne route. The first would be obligate, which is because they're obligated, they only transfer through the inhalation of small particle aerosols. And the classic example of that is tuberculosis, because it really only transmits via the airborne route, not through droplets and not through contact. So you won't get tuberculosis from touching a surface that somebody who has TB has just coughed on, and then say eating a sandwich or touching your mucous membranes. You have to actually share the breathing space with the infected person and breathe in the droplet nuclei or small particles that they've expelled through their respiratory tract. The next is preferential, where natural infection results from transmission through multiple routes, but these organisms really kind of prefer the airborne route. So that's the predominant route where they would be more likely to transmit, such as measles and varicella, which can both be droplet, but prefer to be airborne, or more commonly are airborne. And then finally, there's the opportunistic airborne infectious agents. And that's these are ones that naturally cause disease through other routes than airborne, but under certain circumstances may be transmitted via fine particle aerosols. That's such as smallpox, influenza. We know that that was true for SARS, and it's believed to be true for COVID-19. It's also true for norovirus. So airborne precautions is a set of multiple precautions. Preferentially, if a patient is known to have one of those airborne infections, they would be placed in what's called an airborne illness isolation room. And that's a specialized room that is negative pressure, meaning that the air is exhausted from that room, it leaves the room, but there's no air vent bringing fresh air in. The only air coming into the room is, say, under the door. And that creates negative pressure in that room. It has to be monitored to ensure that the amount of pressure is correct, that it doesn't allow air to then escape into the surrounding areas. If a new room is being built, it has to have 12 air changes per hour. For existing rooms, it's 6. And again, the air is exhausted either directly to the outside or recirculated through a HEPA filter before being returned to the building. It's not expected that dental practices would have an airborne illness isolation room. So that's why if you have a patient who is positive for COVID-19, is either been tested positive or has the classic symptoms and so is presumed positive, those patients should be treated only in an isolation room and therefore should not be treated until their infection has resolved. If they have an emergency need that they must be seen immediately, then they should be referred to, you can do one of two things. One would be you refer them to a facility that is able to take these types of precautions. And if that's not possible, you would do the minimum amount of work possible and not do any aerosol generating procedures, because really the virus itself is believed to be transmitted through the airborne route only if it's aerosolized. So if it's still droplet route, you can take, your droplet precautions and the other PPE precautions I'm going to talk about and use those to treat a patient. But those patients, again, should have their treatment deferred until later, until they're well, or preferably refer them to a hospital setting where airborne precautions could be taken. There are some considerations for modifying practices that have been suggested, such as, preparing your space appropriately, monitoring everybody who works in the practice to ensure that they're not coming down with symptoms of COVID-19, monitoring every patient that comes in to look for symptoms, doing patient follow-up by calling the patient a couple days later. How was your dental treatment? Just following up. How are you doing? And by the way, have you had any symptoms of COVID-19 or had a positive test since the last time we saw you? And then we'll talk about the clinic space cleaning and decontamination, the PPE and hand hygiene, and then workflow. So we talked before about the hierarchy of controls, right? That we can't do elimination or substitution, but we can do some administrative controls, such as avoiding aerosol generating procedures when possible. Right now, the use of ultrasonic scalers for hygiene is not recommended, simply because it does produce an aerosol, and you can still do hand scaling and root planing with hand instrumentation rather than using the ultrasonic scaler. So it doesn't eliminate the ability to provide preventive services to patients. The suggestion is that we alter it for right now. And then if you do have to do aerosol generating procedures, such as with a high-seat handpiece, use four-handed dentistry, and high volume evacuation suction, the use of a properly placed dental dam. Those are all things that will reduce the amount of oral fluids contained in the aerosol, or will reduce the amount of aerosol that's leaving the patient's mouth. Also, limiting the number of dental healthcare personnel that are present during procedures to those that are essential for patient care and procedure support, so that you don't unnecessarily expose anyone to those aerosols. So some of the things that we can do to prepare for returning is think about, how can we make a safe environment? And when we know that the things that we really need to do to prevent the spread of COVID-19 is avoid having close contact with other people, especially unprotected contact with no, mask. Wash our hands and perform hand hygiene frequently, and then avoid touching your face and your mucous membranes. And so how are we going to help our patients do that? Well, first, if we don't have things that are used among multiple people in a waiting room, that's helpful. So removing toys and books and magazines. If you have furniture that can't be wiped down, maybe cover it. And if you do have furniture that can be wiped down, wipe it after each patient or client. Consider putting a label, do not sit, or crossing out, or placing a sign on chairs if you can't remove them, to create 6 feet or 2 meters of distance between patients that may have to wait temporarily in a waiting room. Or better yet, try to keep patients out of the waiting room. If it's possible, could you have your patient call or text you when they've arrived? And then you can let them know when you have a treatment room ready for them to come in, and then they can go straight to the treatment room and not have to wait in a waiting room. If you have a doorbell, you could use that and ask the person to wait outside, and that you'll come and get them. And again, you can have somebody call or text a client or a patient when the exam space is available. We also are trying to keep people from bringing a lot of visitors with them. So if a patient needs care and that patient doesn't require support, say, it's a healthy adult that there's no language barrier or anything like that, then have them come alone. They don't need to bring a spouse or family member or friend. It's better not to have more people around. Of course, if it's a child, a parent can come, but you should ask them to see if they have other children, can they have somebody watch those other children for them when they're bringing the child for treatment, so that you can, again, reduce the number of people that are in the practice or in the office to help prevent people from accidentally having close contact and potentially spreading the infection. Create job lists for the scheduled cleaning of waiting area, registration desk, restrooms, anything like that. So, having a set schedule where you're going to enhance the cleaning and disinfection of all areas within the clinic, where we've always really focused mainly on the treatment areas. We now really need to think about, where have patients been, what have they touched, can we clean and disinfect those touch surfaces a little more frequently than we used to. Things like door handles, the arms of chairs, if there's a counter where they check in, that countertop or pen that they might use to sign something, those should be the areas that we emphasize for cleaning and disinfection. And this is just a mock-up of, so you can see what a waiting room might look like, where, they've put signage on the chairs so that people aren't sitting too close to each other. And then you would want to remove, again, paperwork and things like that that would be touched by multiple people. So for patients, you want to perform a screening. Ideally, the screening should occur twice, if possible. If you call the day before and talk to the patient, confirm that they're coming for an appointment, and then ask them if they've exhibited any signs or symptoms of COVID-19, such as, do they have a fever? If so, is it over 100 degrees? Have they had a cough or trouble breathing? Have they had diarrhea or a sudden loss of sense of smell or taste? All those symptoms that we've heard about. And so once they've passed that, then when they come the next day, if it's possible to do the screening outside, that's what's recommended. But if not, you can do it in a waiting room. If you use an electronic record, you might use that to record the symptoms, or you could just write it on a piece of paper. But consider doing a verbal check with the patient to make sure that they understand the questions. These, do you have these symptoms? And if available, take the patient's temperature if you can, preferably with, an infrared thermometer that doesn't have to go inside their mouth. And then make sure that people, as they're coming in, are wearing a mask until they're seated in the exam area, and then they can remove that mask when it's time to start the dental treatment. But by then, you will put on all of your personal protective equipment. So, and also think about this, so a patient comes in and they have a fever of over 100 degrees. Now, it could be due to a dental infection. You want to be sure to rule that out first. If somebody's coming in with a big abscess, they might also have a low-grade fever, right? But if not, and they have a fever, what will you do? Will you give them a mask and tell them to go home? That would be the right thing to do. Or tell them if they're acutely ill that they should go to a medical provider and seek medical care. If the screening was done outside, you won't need to decontaminate your waiting room. But if it was done inside, certainly the person doing the screening should be wearing their PPE so that they don't have an exposure. But then you want to disinfect the area that patient's been in, particularly if they've been coughing. And then consider exam space zones based on, their proximity to other areas, whether or not they'll disrupt the workflow that's going on. And do you have good airflow and isolation in the area where you're doing the screening? So in terms of planning your workspaces, think about your workflow so that can you minimize cross traffic? I mean, depending on the layout, you may or may not be able to, for instance, have one directional pedestrian flow where, okay, we're always going to go in this direction so that we don't cross each other. I know that in our own clinics, we've been able to do that in some areas and not so successfully in others. So then what we do is we say, well, at the very least, if you're going to be walking in this direction, always stay to the right or to the left, whichever it may be, so that you can minimize contact with each other. Each workspace should include a space. So if each treatment room should have a spot where you can put on, which is called donning or doffing, take off PPE. Also, if you have an open space where there's a lot of dental chairs that are real close to each other, maybe space people out and don't use every single chair. Alternate them so that there's at least 6 feet between chairs, and ideally some form of a barrier, even if it's a curtain that you put between the chairs, that's helpful, but you don't want to interrupt airflow. So you have to be careful when you're doing putting in any type of a barrier, in that you don't cause a situation where there's no airflow to a space. Because one of the main things that's helpful in eliminating airborne particles, the small particles that we talked about, or droplet nuclei, is good airflow to get the air moving and turn the air around in the space. Look at your heating, ventilation, and air conditioning system. Can you enhance the filters on those? You can also look at airflow. So look at where does your air come in and where does it go out? And you can, if you're not sure if you have vents that all look the same, you can check with a tissue to see, is it pulling it towards the vent or is it pushing it away from the vent? So if it's pulling it towards the vent, that's an air return where the air is leaving. And that would be an ideal place to position a patient, because then the air flows from the patient out. Or if you're in a smaller setting where there isn't necessarily ventilation pushing air out, there's only ventilation air coming in, such as in an air conditioning unit or a heater, you might want to position, if possible, the patient near an open window. Open windows will also help increase your airflow. If you can upgrade your filter, that would also be helpful. There are different ratings for filters, and the higher the number, it's called a MERV, the more efficient that filter is. Make sure that the staff spaces and supply areas where people might be working that don't necessarily have on respirators and things like that, are clean spaces, that the air's not flowing from the patient care area over to that area. And you can also consider supplemental ventilation. There's things like freestanding HEPA filters that will increase your ventilation too. If you have a break room or shared business offices or shared registration spaces, again, people should try to keep their distance, the 2 meters or 6 feet apart, should wear face coverings such as a mask or other type of protection when they're around other people, and then clean those spaces regularly. If a person can be sequestered, such as you have an office with a door and you can go in your office and close the door to do whatever work you need to do, and you're sufficiently isolated from other people, you could be in that space without masking, because some people need a break from wearing the mask for a little while. Go into an empty office and you can take off the mask at that, and then do whatever say kind of clerical work that may be being done, and then put the mask back on before you leave. And then if you have a supply room or a storage area, only enter it or accessed by clean staff. So you keep everything in there clean, and that would mean that they have their mask on and they either wash their hands or use hand sanitizer before going in there, or put on a pair of clean gloves to go in and handle items. Also look at your exam and treatment areas. If you need to alternate the use of spaces so that you can allow adequate time for cleaning and for the disinfectant to dry. And if you have chairs, again, that are right next to each other, try not to put patients too close to each other, but alternate them or alternate your appointments. And some people have found that they can't see the same volume of patients that they were seeing prior to COVID-19, at least for right now. These are not necessarily things that are going to be necessary forever, but during a pandemic outbreak of a disease that can be transmitted through the airborne or droplet route, there are certain precautions that must be taken if we want to keep ourselves, our patients, and our colleagues safe. Remove any cloth curtains, or if you have them, treat them as contaminated by not contacting them. I know I've seen one space where they needed to put a barrier between patients, and so what they did was, instead of a cloth curtain, they used a clear plastic curtain like you might see in a shower or a bathtub. And then there's screening of all staff members. That's for the dentist, dental hygienist, dental assistant, dental nurse, any person who's going to enter the facility, even such as receptionists and office managers, people who are not treating patients, should also be screened. And that's because working in a close, working together, you're going to be in close proximity some of the time. There's no way to possibly stay 2 meters away from each other all the time. So you want the members of the staff to self-report symptoms that would prevent them from presenting to work. And they should do that each day before arrival at work. And then on site, you could screen again for temperature and symptoms. So somebody should, everybody should be informed, this is what you need to do. Every morning when you get up, take your temperature, assess whether or not, you're feeling well. I mean, really think about that. And if you're not well, then you shouldn't come to work. And one of the things that requires is that we have flexible policies on work attendance, which can be hard to do. I understand that, but we don't want people feeling like if they don't come to work, they're going to lose their job. And so therefore, then they come to work when they're sick and they just try to mask their symptoms. Maybe they have a fever, but they take some aspirin or acetaminophen, before coming to work, so that even if you take their temperature, they're not going to show the symptoms. Or they have a cough and they take a cough suppressant. You really don't want that to happen. And in order for us to be able to stay safe at work, it's going to be required that we have that kind of flexibility and accommodation for people who aren't feeling well, so that, again, they don't have an incentive to come to work when they're ill. There should be source control, which is very simply put, wearing a mask or a cloth face covering anytime people are in the practice, in the office. And then consider assigning or reassigning staff to patients based on their risk to each other. So if you have staff who are, say, in the high risk category, such as over age 65, underlying medical conditions, maybe they could be assigned to clients or patients who are also low risk, people that aren't working outside of their home, that aren't encountering a lot of other people, because most of these transmissions seem to be occurring in multi-generational homes, where people live with a lot of other people. They're also occurring at gatherings such as birthday parties, weddings, funerals, anything like that, dinners with people that you don't live with. Those are all considered high-risk activities. And then consider maintaining a searchable database of staff members in contact with specific clients. So, if a client or a patient calls and says, I had an appointment yesterday, and today I got the results of my COVID-19 test, and I found out I'm positive. So I was positive when I was in the dental office. You'd want to be able to identify, especially if you're in a larger facility, identify which staff members had contact with that patient, so you can talk to them about whether or not they were taking appropriate precautions at the time, or whether or not they might need to be quarantined, for instance, if they weren't wearing a mask. So talking about some of these masks that we wear, there's certainly surgical or procedure masks. They can look like, these have pleats in them that look like kind of a cascading waterfall effect. So you make sure that that's going downwards. A lot of them have a plastic formable nose piece that helps make a seal over the bridge of your nose to help keep the air from escaping and creating a fogging of the glasses. And masks are generally evaluated on their ability to filter bacteria, on their small particle filtration. Usually medical or surgical masks can filter out about 95% of particles that are 0.1 micron in size, so really, really small. They also measure how well the airflow can pass through the filter medium, the mask material itself, and that's considered its breathability. And then how resistant is it to fluids? So there are different levels of fluid resistance, but medical surgical masks generally have some fluid resistance. Whereas when we look at respirators, and these are just some examples of types of respirators, these are called N95 respirators, but there are others too, that have different designations. So a surgical respirator, if it's an N95, acts as both personal protective equipment, so it's protecting you from from breathing in particles or droplet nuclei that may contain infectious agents, but it's also creating source control. So all of the air going into your respiratory tract and out of it passes through the filter. So unlike a surgical mask, which air will flow out from the sides and the other edges, and also through the filter itself, this will create a seal to the face so that there won't be any airflow out or in. Now, you've seen probably some of these respirators, different types of respirators. Some are KN95, those are the ones generally made in Asia. There's N95s, I think there's FFRs, filtering facepiece respirators, level 2 and 3 from Europe. But some of them have this exhalation valve that can't be used as source control. And so when I see people walking around outside that are supposed to be wearing a mask, because here where I am, everybody's required to wear a mask in public. So even if you're just walking around outside, you're required to wear a mask. But some people are wearing these that have an exhalation valve. But that's not source control, because all it does is it filters everything going to you, but it doesn't filter what you're expelling out of your mouth. So these are really considered, they're used for things like industrial uses, painters and people that work around chemicals, because you don't care. And in that case, all you're trying to do is make sure that you don't breathe in particles. It doesn't matter if you breathe particles out. So just So you know that this is not considered source control. It only protects the wearer. And what we're looking for is control that protects both the person wearing the protection and also the people that you may encounter. So all of these tight-fitting respirators, like the N95, KN95, and others, have to have a tight seal between the respirator and the face or neck, wherever it encounters the skin of the person who's wearing it. And then each time a person puts one on, they should do a quick check to make sure that it's been sealed properly. And that's just to determine whether or not the respirator is properly seated to the face. So no air should be escaping around the edges of that respirator. And then there are also face shields. So face shield, like a clear plastic face shield, especially if it wraps around the side of a face a little bit, can provide good protection. During testing of an influenza-laden cough aerosol with a volume median diameter of 8.5 microns, wearing a face shield reduced the inhalation exposure of the worker by 96% in the period immediately after a cough. So as you can see, a face shield is also excellent protection, especially in combination with a filtering facepiece respirator or a filtering surgical mask. The face shield also reduced surface contamination of the respirator under the face shield by 97%. So in situations where you need to use a face shield, or use a respirator for an extended period of time, wearing a face shield also protects it from becoming contaminated or wet. So dental health care professionals should be trained in the proper use of personal protective equipment. And there are there's some little posters or guides that if you're interested, I'm showing a picture of them here, that you can download for free and print if you'd like from the CDC. And this is the website where they can be printed from. In fact, if you go to www.cdc.gov, you'll find that there are multiple resources, all of which are free, that you can use. There's posters that you can put up in your office to remind people about things like, 2 meters of distancing, wearing face masks, and that kind of thing, including there are, recommendations and guidelines for infection control. Currently, the recommended sequence for putting on your PPE or personal protective equipment is to always start by performing hand hygiene, either washing your hands with soap and water or rubbing your hands with alcohol-based hand rub. Put on a clean gown or protective clothing, and then put on your surgical mask or respirator. Make sure that it's put on correctly and secure. And then put on your eye protection, either a face shield or goggles. And then put on clean, non-sterile gloves, and then enter the patient room. So the idea here is that the patient should be brought in first, and then you put on your PPE and then enter the room or care area. And that's different than our normal standard precautions. This is, again, for this period of time, interim guidelines that could change. And that's an important caveat to remember, is that, information is changing so rapidly and the science is emerging. And as we all know, science is a journey of discovery, right? It's not cut and dry. This is true today, and it's not that these things are false or untrue. It's that as the science progresses and we learn more, we also may have to change recommendations, change the practices. And so it's important to keep track of what's going on, especially during periods of rapid change, which we're experiencing now. So after the patient's been dismissed following dental care, first remove gloves, and then protective cover the gown, and either dispose of the gown or put it in a laundry bin if it's reusable, and then leave the patient care area. And after you've left the treatment room, perform hand hygiene again, and then carefully remove your eye protection by grabbing it either by the strap if it's a face shield, or by the sides if it's goggles. Then carefully remove, and then also clean and disinfect the reusable eye protection using, probably your surface disinfectant, and discard disposable eye protection if you're using that after use. And then finally, the last thing you remove is your surgical mask or respirator. Again, not touching the front of it, which may be contaminated, but touching the ties or the straps. And then again, perform hand hygiene just in case you've accidentally contaminated your hands while removing your PPE. So there's a combination of PPE and behavior that'll help keep you safe. And that is, just putting on the PPE isn't enough. You have to be sure that when you have your PPE on, don't touch areas with your contaminated gloves that may not be disinfected later. Don't reach into your pocket to get out your cell phone by lifting, your isolation gown and going underneath. Don't touch things that just don't need to be touched. And then again, following these additional safety measures, such as suctioning and dental dam and using four-handed dentistry, and then having a face shield that protects your eyes, the front of your mask or respirator, and your skin on your face and neck that may, you may have a scratch, or maybe it's, you have some non-intact skin. And then what you want to be sure, is that we change our behavior and habits. We're so used to, of course, as human beings, we're social beings. We're used to being, close to each other. And when you talk to one another and, such as, typical setting on the left, but we can't do that right now. And the same thing, certainly in dentistry, we should never have been standard. The picture of the dental procedure isn't even following standard precautions, because you can see they're not wearing any type of a face protection and they're wearing short sleeves. So, this would never be appropriate, and especially not appropriate now. So some people have needed, because of shortages, to either extend or reuse their masks and face shields or respirators, where they're worn multiple times throughout the day. If you have to do that because you really don't have any other option, you need to take care to remove it carefully, never touching it, the front of it. And then if it's plastic, like a face shield, wiping it down. If it's not, it's like a respirator, then really what's recommended is that you don't use it for 2 or 3 days, that you have a few of them and you put them in a paper bag and label the bag with your name and hang it somewhere and give time for any microorganisms that may be on there to die off before you reuse it. And even then, you wouldn't want to touch the front of it with your bare hand when putting it on. You'd need to wear clean gloves when redonning a respirator. Ideally, you wouldn't need to do that. They really are considered single use only, but we understand that in these times that it may be necessary. So you can see here how, somebody's, put their respirator in a bag and then hang their face shield up, and then they have their name labeled and maybe put the date on it so that you can have it stored in a well-ventilated area. But again, if you're going to reuse PPE, not recommended, but if you have to, always wear gloves when handling it. And then have fresh gloves for treating the patient, because you don't want to contaminate your gloves by touching contaminated PPE and then go and touch a patient and cross-contaminate them. So there are 3 methods that are being looked at for decontamination of any type of filtering facepiece respirator, and these are considered the crisis capacity standards of care. So these would not be considered our normal standard of care. This is for when we're in crisis situation. Severe shortages of PPE are not, it's not a cost issue, it's a shortage issue. So cost alone is not considered a criteria for reusing PPE. It's purely based on demand. If the demand is high and supplies are low and you need to keep treating patients, then you take these types of measures because they are definitely a compromise. They're not the highest level of safety that we could provide. But what they've looked at and found that there are 3 possible methods of decontamination that may be effective, and that's ultraviolet germicidal irradiation called UVGI, a vaporous hydrogen peroxide, and a certain type of moist heat, not an autoclave, not a typical autoclave that we use would not be considered appropriate for filtering facepiece respirators. And they also caution that decontaminated filtering facepiece respirators should not be worn when performing aerosol generating procedures because they get too contaminated and therefore they should be discarded. And also, at least in the US, it's recommended against decontaminating the KN95 respirators because they aren't they're not held to the same rigorous standards as a N95 would be in the US. Also, in cleaning the environment and the clinical environment, don't manually push down trash, because you don't want any aerosolization of the waste. Any COVID-19 waste, hopefully you're not treating patients that are infected with COVID-19. You're able to delay their treatment. But if you do, then that waste is not considered, biohazardous. Look for cleaning products that list human coronavirus on the list of what they kill. So disinfectants, will generally on the label have a list of the organisms that they're effective against. So, human coronavirus is fairly easy to kill. So you want to look for one that is effective for that, plus hepatitis, HIV, and preferably TB, because tuberculocidal disinfectants have the broadest spectrum because TB is the most difficult to kill. Encourage frequent hand hygiene with alcohol-based hand rub or soap and water. And if you're using an alcohol-based hand rub, it should have a minimum of 70% isopropyl or 60% ethanol. Don't combine different types of cleaning products, either directly or indirectly. Say, don't use ammonia to clean something and then bleach to disinfect it. You could have create a hazardous combination. Always follow instructions for any kind of dilution. Your shelf life and expiration dates. And if you are going to make your own, then do it carefully and then date it for when you've mixed it up and discard it when you're done with it. You can also do a risk reduction follow-up where 1 to 2 weeks after a patient's visit, you recheck via phone or text to verify that they haven't had any symptoms. Always ask patients to let you know if key symptoms of COVID-19 do appear shortly after their visit or if they have a positive test. Some dental offices say, well, we're going to see patients in a family unit. So that way it's safer for the patients. They've all been quarantining together. They're the ones who are coming into the dental office together, and they're not encountering a lot of other patients. And you can encourage staff members to continue to reduce their own risk, not just at work, but also outside of work, because what we do outside of work in these times can have a major effect on our work environment and the people that we work with. So if we're being safe at work, but we're not practicing safety at home, we're not avoiding large gatherings, we're not wearing face coverings when we have to go out to do essential things such as go to the market, then we're putting everybody else at work at risk along with ourselves. It's important to remember that antibody testing does not imply immunity to COVID-19, and that negative screening tests can also miss early cases. So we don't rely on antibody testing as part of our screening process. You do have available to you perhaps a PCR or the molecular test that can be done, and that's the test that's used to diagnose COVID-19 in active case, and that generally takes several days to analyze. So look at your policies too. Modify existing infection control policies to address things like source control, the new PPE requirements, ventilation, develop a written respiratory program, and develop exposure management plan. What is an exposure? How do you define one? And there's guidelines for that. Develop reporting process. Is your local health department prepared to help identify contacts? They may not be. You may have to do it yourself. And think about quarantine and self-isolation. And then finally, I would just like to share with you a couple of resources that you may find helpful. These are their websites. The AIHA, which is a public health organization, has a guide for returning to work for dentists, and it's at backtoworksafely.org. OSAP, my organization, and the Dental Quality Alliance, DentaQuest Alliance, have put together very recently a best practices for infection control in dental clinics during the COVID-19 pandemic, and that's a checklist. You can go to the OSAP website, it's free. It's www.osap.org. I have the whole URL listed there, but if you just go to the OSAP website and look that up under resources, it will be there. And it's a checklist that you can use to make sure that you've checked off all the things that are recommended that we do, and it may have things there that you could consider. They're not necessarily required. And the American Dental Association has also put together, and you don't have to be a member for this one, which is nice because many of their resources require membership, which is very expensive. The ADA has a return to work interim guidance toolkit, which contains a hazard assessment. It has also a patient education center. They also have a checklist for returning to work and a number of resources that can help you with some of your policies and procedures, such as identifying, what is an exposure? When would you have to quarantine or self-isolate? And that is at ada.org. And again, you can access that whether or not you're a member. And I'd like to thank you all for your time in attending this program, and also thank the organizers for inviting me.